Good afternoon, everybody. Um, I'm delighted to invite you to today's um, uh, next to last fall quarter lecture in the 39th annual lecture series of the MacLean Center. The general topic, as you know, is ethics in the COVID-19 pandemic, medical, social, and political issues. We're honored today to have as our speaker Dr. Peter Angelos. Peter is the Linda Kohler Anderson Professor of Surgery, the Vice Chairman for Ethics Professional Development in the Department of Surgery, the Head of Endocrine Surgery, and an Associate Director of the MacLean Center. Dr. Angelos is a highly regarded surgeon who has extensive experience in surgery of the thyroid, parathyroid, and adrenal glands. He's also an expert in treating endocrine cancers as well as islet cell tumors of the pancreas. Peter has a special interest in minimally invasive endocrine surgery and has served as past president of the American Association of Endocrine Surgeons. In addition to being a surgical leader, Peter Angelos is recognized expert and a national leader in surgical ethics. Indeed, he's probably one of the original creators of the field. And since completing his MacLean Fellowship in 1992, Peter Angelos has written widely on ethical issues in surgical practice and on how best to teach surgical ethics to surgical residents and to ethics fellows. Since Dr. Angelos' return to the University of Chicago in 2006, the MacLean Center has trained more than 80 or 85 surgeons in the field of surgical ethics. This is by far the largest number of surgical ethics trained fellows in the world. Dr. Angelos is also aligned closely with the American College of Surgeons to create a joint surgical ethics fellowship program with them. A great writer, Peter Angelos has published more than 200 articles and book chapters related to his research on improving outcomes of thyroid and parathyroid surgery, minimally invasive endocrine surgery, best practices for thyroid cancer treatment, and of course, what the field I talked about, surgical ethics. In 2017, Peter and another one of our former fellows, Alberto Ferreras, co-edited an American College of Surgeons book entitled Ethical Issues in Surgical Care, a wonderful book. In fact, MacLean Center former fellows contributed 50% of the chapters to that book published by the American College of Surgeons. Currently, Peter is working with two of our former fellows, Dr. Vasil Lochnia and Dr. Peggy Kelly, to complete a new book entitled, quote, Difficult Decisions in Surgical Ethics, a book that will be published in 2021. Dr. Angelos' talk today is entitled, I quote here, The Unknown Unknowns, Surgical Ethics in the Time of COVID-19, end quote. Please join me in giving a warm welcome to Dr. Peter Angelos. Peter.
Mark, thank you very much. I definitely am honored to be here and very much appreciate your kind introduction. And I'm going to, hopefully you can all see my screen now. And I'm going to go ahead and present this topic. I have to tell you that it is, it's really difficult for me at least, to give a presentation like this that is, scheduled for such a long period of time in this sort of virtual format, because I always feel as though sort of the foundations of education are engagement and perhaps a little bit of entertainment. And I find it difficult to do both of those things in this format. But that being said, I'll do the best that I can and certainly leave some time for discussion at the end. So let me, so I have no disclosures with respect to this presentation. By way of outline, I do want to share with you a little bit about how COVID-19 has affected surgical care. And I'm going to speak obviously from my perspective here at the University of Chicago. And for people who practice in other cities and other countries, you know, obviously things are going to be somewhat different. But I do think that there's probably some similarities that overarch the different locations. I'll talk a little bit about some of the underlying assumptions in surgical decision-making and how those changed during the pandemic. I'll spend a little bit of time defining and then talking about medically necessary time-sensitive operations. And so this is the term that we actually came up with at the University of Chicago to refer to things that are not emergency surgery, but as to distinguish them from the more commonly used term of elective surgery. I will spend a little bit of time talking about surgical informed consent and how it has changed over time in the course of the pandemic. And then I'll mention a little bit about surgical clinical trials. I'll talk somewhat about the impact of the pandemic on the relationships that faculty and surgical residents have had, and then touch on the worsening problems of disparities, which I know others have spoken on and will address in much greater detail than me. And then talk a little bit about challenges to developing trust with patients in a virtual world. And I'll certainly end with some time for discussion. So by way of introduction, let me try to explain the quote that I used in the title of my talk. So this is what Donald Rumsfeld, who was Secretary of Defense for George W. Bush, said in February of 2002. He said, "We know there are things we know we know. We also know there are known unknowns. That is to say that we know there are some things we do not know. But there are also unknown unknowns, the ones we don't know we don't know." Now, I have found that to be such an apt description of much of the past 9 months, because there's been a constant change in what we believe about how this coronavirus affects people. We've had a lot of changes in the recommendations from a public health perspective. And similarly, we've changed our approaches in the operating room, in the hospital as a whole. And so I do think that this quote very much emphasizes how little we knew at the outset and how we still know a lot more than we did in March, but still there's a lot more that we don't know. So let me take you back to March of 2020 and the University of Chicago experience. And so, much of this people know, and so I won't belabor it, but on March 17th, we had a virtual complete shutdown of non-emergency surgery at the University of Chicago. And it was sort of memorable for me personally because I had been giving a couple talks at McGill University the week before. And while I was there, I received an email saying that the University of Chicago had forbidden all all work-related travel, but I was already in Montreal, so, I had to give the talks. And then I crossed over the border from Quebec into New York State and spent some time with my mother, who lives in northern New York State, and then got back to Chicago only to hear that the border had been closed. And so it was really a very strange sort of series of events. In response to state directives and in accordance with the American College of Surgeons, we stopped all surgery that was not an emergency. So on Tuesday, I had, I think, 5 patients scheduled for surgery, Tuesday, March 17th, and those all had to be canceled. And over the next 6 to 8 weeks, it was really an unprecedented time of stress on the medical center as a whole, on the surgical residents, and I would say the entire surgery department. And again, I don't want to minimize the impact that it had on other departments and other residents. I'm just, sharing my experience. For almost that entire 6 to 8 weeks, there was almost no non-emergency surgery that was being performed. And at the time, our clinics were closed because we hadn't yet sort of figured out how to do virtual patient visits, which, we're now better at than we were at that time. All of our clinics were closed, and surgeons were specifically asked to stay home unless it was necessary for them to be in the hospital to render patient care. And so this was a huge shift for most of the surgical faculty. And as a result, if you take a bunch of surgeons and you tell them, you know what, you can't operate, and you can't see patients in clinic, and you're not supposed to come to the hospital unless you have an absolute reason to be there to render patient care, there were a lot of people like me who had a lot of extra time on our hands. And it wound up being a very fertile time of discussion and collaboration. And many of the things that I'm going to talk about today are related to papers that I wrote with colleagues at the University of Chicago and elsewhere. And I will put in all of those references because I certainly don't want to take credit for all of these ideas. We had bi-weekly department-wide virtual conferences with discussions about ethical implications, talking about challenges that we were likely to face as an institution. And I have to say, it was pretty amazing to see 100 people log in twice a week to talk about these topics. So some of the things that I think we learned in surgery, hopefully others in other specialties will find that there are some parallel implications. I do think that it's valuable to think about how our response to the COVID pandemic has led to a greater appreciation of a number of important aspects of surgical ethics. And so, I'm always trying to hope that that what we've learned from this experience will help us in the future. But of course, that remains to be seen. So one of the most significant things that was very clear early on was that there was a fundamental shift in the ethical foundation of surgical care. Again, most people will appreciate that surgery, at least as practiced by most surgeons, and certainly by me, is focused on a single patient at a time. And so, we can only operate on one person at a time. And I do feel as though, at least for me, someone who has difficulty with multitasking, one of the great things about operating on people is that when I'm in the operating room, I can focus entirely on one patient at a time. And that person can have all of my attention. And it's true, I occasionally get pages, but I'm not able to answer them because I'm scrubbed, I'm sterile. The pager's not sterile. So someone else has to answer them and say, I'll call back later. Or if we're really busy, those pages just don't get answered. And people figure out other ways to take care of things. So I do think that this notion of taking care of one patient at a time is something that, we I at least sort of took for granted. That's what we do. And when we make recommendations for our patients, it was traditionally to benefit the individual patient. And so if a patient's asking me, well, what do you recommend? My recommendation is based on what I think will be of benefit to that person. But with COVID-19 and the changes that we were seeing in medical care, it really forced surgeons to shift from a very strongly patient-centered ethics to a public health ethics. And I'll try to give you some examples as we go on about, why I think that happened. And surgeons, as a result of this shift, had to change from focusing on, what is best for my patient to this broader view of what's beneficial to the community or to public health as a whole. And, for better or for worse, most surgeons in the US rarely have faced the necessity of making decisions in the context of an absolute scarcity of resources. But in fact, in the midst of early on in the worst of the pandemic, that's exactly the situation in which we were in, where we had to make decisions in the face of scarce resources in a way that we don't generally have to do very often. And I do feel that this shift in how we were forced to make recommendations for patients has caused significant moral distress among surgeons and probably amongst many other healthcare workers as well. So, we had to cancel surgery, as I mentioned, for hundreds of patients. And there was really a significant emotional toll of telling patients who may have been scheduled for surgery for a long period of time that, their operations were going to be postponed. And at the mid-March, when we were canceling cases, we didn't, we weren't postponing them for a week, 2 weeks, 3 weeks. We were just saying, we're sorry, you can't have your surgery as scheduled. And we will be in touch when we can get you rescheduled. And so this was really an unusual circumstance in which we were unable to respond to our patients' wishes, even if they were willing to accept the risks. And so I do feel as though this necessitated a real shift to a greater level of paternalism than most of us are used to in our practices. And so, I can tell you that a number of patients that I spoke to said, well, I'm willing to take the risk. It's okay. I'm healthy. I feel much more that I need to get my thyroid cancer removed than am I concerned about getting infected with this virus. And yet I and everyone else who is in the same situation had to say, I know you're willing to take the risks, but we cannot allow you to take those risks, or we are not allowed to operate on you. And so it was really a very different way of having conversations with patients than most of us are used to. Now, there were early reports of much higher risks of surgical complications in patients who were asymptomatic but COVID positive at the time of surgery, or those who contracted the virus in the perioperative period. Now, again, you have to realize that, here we know very little. We had one unfortunate, tragic case where a patient who had a seemingly straightforward non-emergency operation who had a devastating complication and then subsequently tested positive for COVID. And so we didn't know, was that just, is this just a bad complication that sometimes happens? Or was this in fact as a result of having the disease? And again, you have to remember that at that time, we did not have the ability to test everybody. And so, we would ask patients if they had fevers and, any flu-like illnesses in the past week, or were in contact with people who did. But largely we operated on people without knowing their COVID status. So, some of those ethical issues in the care of surgical patients in the midst of the pandemic, I want to just reemphasize. I mentioned that there was moral distress for providers. And again, this is based on the inability to provide exactly the care for patients that the surgeon might want to provide, that the patient might want to receive, but we were not able to provide it. And so, that's a tough situation to be in. We know from studies of SARS and the impact of the SARS outbreak on caregivers that there's a potential lasting impact of this distress on the well-being of healthcare providers. And so this is something that, I think all of us in medical care are going to have to think about in the upcoming months and perhaps years. We also know that there was a huge emotional distress for patients. And, I don't want to underestimate how hard it was for people to be told that, you cannot have the operation that you had planned for. You cannot get the tumor removed that you were told you need to have removed. And even discussing with patients, well, what are the implications of waiting, are difficult, because as I find myself telling patients regularly, nobody's really good at predicting the future, and physicians aren't any better at it. And so, we would tell patients we don't anticipate that it will have a significant negative impact on their life, but we don't really know. Certainly patients worried that there would be higher surgical risks if they had surgery during the pandemic, but they also worried that if they didn't have surgery and if it was postponed, they might have higher surgical risks because of their disease process advancing. So this brings us to this issue of medically necessary time-sensitive surgery. And I do have the reference here on the bottom of the slide. And really, this was a collaborative effort. Dr. Vivek Prashant, the first author on this paper, really did the bulk of the work in bringing these ideas together. And so, the issue is that in a crisis setting, there is a tendency to conflate elective with optional when you talk about surgical procedures. And so elective surgery was sometimes thought, well, is that really necessary surgery because it's elective? Now, of course, from a surgical point of view, elective refers to the fact that the condition allows for the surgeon and the patient to elect the timing and schedule the operation, not it is an emergency, right? So emergency operations happen in the middle of the night whenever the patient presents with the emergency problem. But elective operations happen at a scheduled time without any negative impact, as far as we can tell, on outcomes. And so when we in surgery would talk about elective operations, we often found that patients, as well as government officials as well as administrators were sometimes, saying, well, is it really necessary if it's elective? And so certainly in March and in April, it was absolutely necessary to curtail surgery to allow hospitals to get rid of, to reduce their inpatient census and preserve the personal protective equipment that was in short supply. It was also an attempt to preserve the potential resource of personnel. So we did not know how likely it was that healthcare providers, for example, OR nurses, anesthesiologists, nurse anesthetists, would be all at risk of getting the coronavirus if they were in the operating room with a patient who happened to be positive. So this lack of sustainability for no elective cases was what sort of pushed us to say, well, we need a way of systematically assessing the risks of proceeding versus the risk of postponing surgery. And as you'll see, there's a number of things that come to play when we have to weigh those risks and benefits. And it was an attempt to systematically score cases across multiple specialties in order to improve efficiency and equitability while also reducing the emotional and ethical burdens on caregivers. And so, I won't spend a lot of time on the details here, but the MENTS scoring system utilized 3 general categories of identifiable factors, and those were the procedure factors, disease factors, and patient factors. And again, the procedure factors, and you would get a score 1, 2, 3, 4, 5. So the higher the number, the bigger the concern. So longer operations, greater level of exposure. If it was likely that the patient was going to need to be in the hospital for a long time, how likely was it that the patient would need an ICU? That gets to sort of resource utilization. How likely are they going to need a blood transfusion? Because again, blood supplies were in short supply. So all of these things had an impact on how we would score the case. We also looked at then disease factors. So this was, is there a non-operative treatment? What is the risk of the non-operative treatment? So there's some non-operative treatments that require patients to come to the hospital every day, for example, for radiation. Well, that might not be a good idea in the midst of a pandemic. So we had to take those things into account. What about waiting for a couple weeks? Or what about waiting 6 weeks? And is that going to affect not only the disease outcome, but also the surgical difficulty and risk? And so you can see here that there's a lot of judgment on the part of surgeons to make these, to rank these things and score them. We added in patient factors. So the age of the patient, comorbidities, are they immunocompromised, that sort of thing. Did they have exposure to a known COVID-19 positive patient in the past 14 days? So again, this was early on when we did not have wide-scale testing. So the scoring system then allowed us to get a score. The lower the number, the lower the MENTS score, the more favorable the surgical risk, the more favorable the risk to personnel, and the more favorable the resource utilization. Whereas higher numbers, worse outcomes for patients, excessive risk to personnel, and lots of resource utilization. And so this was a way of trying to score things so that even as we started doing cases increasingly after the shutdown ended, we didn't immediately go back to full schedule. We had to ramp up slowly. This gave us a mechanism to ramp up in a thoughtful way. And by assigning values to each factor, it really forced surgeons to consider additional factors that we might not generally have thought about, like, how likely is it that the patient's going to need to be in the ICU post-op or need blood, that sort of thing. So let me turn then into surgical consent during the pandemic, because certainly surgical consent was something that needed to change. Again, the assumption with informed consent discussions in surgery is that we as surgeons know the risks and we know the benefits with a reasonable degree of certainty. And then we help our patients to weigh those risks and benefits. So the real challenge was, how should we modify informed consent in the face of these significant unknown risks? So again, there was a lot of fear about what are the risks to patients of having surgery if they are asymptomatic COVID carriers or positive and hadn't yet shown symptoms. And so it was clear that there was an importance in expressing the transparency of the uncertainties with patients when their status is unknown. We ultimately came up with the idea of an enhanced informed consent discussion that had to occur prior to the patient coming to the hospital on the day of surgery, and also had to be documented in the chart. And this, again, a big shift, had to be personally conducted by the attending surgeon. We could not allow a resident or a fellow to be the one who had these discussions. And so again, that's a big shift in an academic surgical department. So some of the components of that discussion were that there was a lot of unknowns, that we didn't know what the true risks were if we operate on COVID patients, that there was an uncertain risk of nosocomial infection during any aspect of the surgical care in the hospital after the operation or even before the operation. We had to explain to patients the changes in the day-to-day operations, no visitor policies that might alter their ability to communicate with family members. We expressed to patients the impact of these pandemic-associated healthcare resource shortages. So it might be harder to get into the emergency room. It might not be possible to get a post-op endoscopy, even if we wanted to. We might not be able to get interventional radiology services. And certainly we also emphasize the importance of advanced directives in a situation in which the risks were thought to be higher. Let me turn now just to talk for a few minutes about surgical clinical trials. And so the real question was, is it ethically appropriate to continue to enroll and treat patients in clinical trials that included surgical intervention? And if we continued such trials, will the patients or subjects be at greater risk of COVID-related complications? And certainly we knew that if we suspend future enrollment, then we may be potentially denying patients the possible benefit of these novel interventions or some improved outcomes, and that was unknown. So first of all, if we look at surgical oncology trials, the way most surgical oncology clinical trials work is that there's often a mandate for specifically timed surgery after neoadjuvant chemotherapy or preoperative radiation treatments. And the decision to proceed with a planned cancer resection for a patient in a clinical trial then had to be very highly dependent on the phase of the pandemic at that particular hospital's location and the available resources at the time. And so the feeling was, if we expedite and prioritize surgical treatment for those patients who are part of a trial, well, then that may be seen as sort of a form of coercion, where you might not ordinarily be able to get your operation, but if you're part of the trial, you are going to be able to. So that did not seem right. And although postponement of surgery may lead to a protocol violation by the predetermined principles of the clinical trial, in the midst of the COVID pandemic, those concerns we thought should not impede the appropriate safety-conscious, patient-centric decision-making. And at the University of Chicago, we attempted to maintain patients who are already enrolled in clinical trials, but we dramatically curtailed new enrollment because of an uncertainty of available resources, and we focused our research efforts on COVID-centric studies, as the whole medical center did. Vascular surgery participates in many clinical trials, and due to the pandemic, all vascular clinical trials, mostly these are of new devices, were halted. And again, using the MENTS framework, vascular surgery really focused their attention on patient care that was related to critical limb ischemia, symptomatic carotid artery disease, and symptomatic or ruptured aortic aneurysms. These are things that really could not be safely put off for any length of time. And by halting enrollment in clinical trials in vascular anyway, it relieved the pressure on surgeons to enroll subjects in these trials that might negatively impact the timely care of other patients who might need surgery. Again, given the small number of ORs available, the limited staff, and limited PPE. Patients, we thought, should not feel pressured to enroll in a clinical trial in the belief that they may be given an advantage in getting to the operating room sooner. So again, it was an attempt to not coerce anyone into participating in a clinical trial because they might think that they would get their surgery sooner. Let me turn for a few minutes to talk a little bit about this issue of the potential disruption of the trust between surgical residents and attendings. And, you know, I do think that there were a lot of things that changed. And, you know, among them, residents were coming to the hospital daily to care for post-op patients. And in many ways, you know, on surgery service, they are frontline healthcare workers. Whereas the attending surgeons were told to stay home unless it was mandatory for us to be in the hospital for direct patient care. And as a result, I think many of our residents and fellows increasingly felt that they were in harm's way, while the faculty were at home, you know, calling them up and saying, you know, how's Mrs. Smith doing after her operation? Lots of things changed. Informal teaching on daily rounds in the hospital was largely absent. We weren't going to see patients together. And I do think that these had a real negative impact on the relationships between the faculty and the residents or fellows. Certainly residents as proxy for faculty were obligated to carry out a disproportionate share of patient care in the setting of heightened risk and uncertainty. And when there were operations that were not postponed, when they did proceed and the patient had a complication or death, definitely the surgeons had some moral distress about, you know, what happened. But the residents who were in the hospital virtually every day, I would say, felt that moral distress even more and questioned, should the patient really have had the operation or not? As a result of a lot of these shifts, we were, as we ramped up virtual clinics, there was a lack of participation by residents in outpatient activities. And so this led to even less opportunity for them to understand the decisions made to proceed with surgery. And there's no question, there is a hierarchy between surgical faculty and residents, and that resulting power discrepancy led residents to sometimes feel uncomfortable raising concerns about whether a specific patient was suitable for surgery, even in the MENTS framework. Because as you saw briefly, the MENTS framework does force a lot of judgments to be made. And so people can disagree about some of those scores. And I do think that residents might have sometimes assumed that operations were being scheduled primarily to generate revenue, either for the institution or for the surgeon. So There were a number of initiatives that we took to try to restore this trust, and that was to facilitate the open dialogue, to bolster peer support groups within the residency, to reintegrate residents as rapidly as possible into the preoperative decision-making process, to adjust faculty teaching so that we specifically addressed why the surgery was medically necessary and time sensitive. We definitely tried to solicit resident feedback on COVID safety protocols, and as they were dealing with things on an ongoing minute-to-minute basis, get their input. And we tried very much to empower residents to engage in informed consent discussions with patients and to address advanced directives. And if a resident refused involvement in an operation, to allow for accommodations within reason, as the resident might be signaling moral or physical distress that needs to be further addressed outside of patient care settings. And I do think that as we move eventually into the recovery phase, surgical faculty need to make sure that we are restoring our usual patient care processes, we also restore the trust of our surgical residents. I think that there's no question everyone, I believe on this call or this discussion knows about the disparities of outcomes of patients with different racial and socioeconomic backgrounds. And this is nothing new, but it certainly has been highlighted. And, the challenges of social distancing on public transportation and in many household environments only exacerbated these disparities. And certainly there are vulnerable populations who are at high risk. And again, think about patients coming to the hospital for surgery, those for whom English is not a first language. Can you imagine if you don't speak English well and everybody's suddenly wearing masks, how much harder it is to communicate? And it may be that your best interpreter is your son or daughter or sister or brother or wife or mother. And those people can't be in the hospital with you. And that inability to have family or visitors in the hospital, I think, only exacerbated some of these problems. I do want to just touch for a few minutes on this issue of trust in the surgeon-patient relationship. And I think, many of you have heard me argue in the past that informed consent is much more about patients trusting their surgeons, more so than about the transfer of information from surgeon to patient. It's interesting that now, I would say greater than 75% of the patients that I operate on have only met me in person for the first time on the day of surgery. So it's a really strange situation to come into the pre-op area and say, "Good morning, it's a pleasure to meet you in person." I've never had that experience prior to the last several months. I have learned to maneuver the image on virtual visits so that I appear to be looking directly at patients so that, I'm not looking off to the side all the time, which is a little bit off-putting if you want to believe that your doctor's paying attention to you. I've gotten much better at my lighting skills. I'm not backlit. I've tried to create an environment in which it's easier for patients to see me. And in fact, maybe it's better that I'm not wearing a mask when we have these virtual encounters as opposed to inpatient encounters. And I have repeatedly given patients the option to have an in-person visit prior to them scheduling surgery, but they've rarely chosen to delay surgery, as they say, just to meet me. So increasingly patients say, "I'm fine, I'm good with scheduling surgery," which I find to be truly astounding that people are able to develop that trust in this virtual environment. And I would say many of my assumptions about how physical proximity breeds trust are definitely now called into question. And I think it remains to be seen if patients who have complications will still feel as good about the surgeon that they only met on the day of surgery as the one that they met in person prior to surgery. So I don't know the answer, but I think that we will eventually learn. So a few sort of reflections, and then I'll stop. Hopefully we'll have some questions. I've definitely, along with everyone, learned a lot in the last 9 months about the risks associated with infection with COVID-19. No one has surgery now without getting COVID testing. It's mandatory. We are no longer filling out MENS scores for every patient, and at least for the time being, we're at full operating room volumes, but that may change. But my conversations with patients about the timing of surgery remain altered. So I now feel that I need to continue to tell patients, we will go ahead and schedule your surgery, and I am hopeful that we will be able to keep to the schedule and get your operation done. But if things change, we might have to call and cancel it for some period of time. As I mentioned, I often meet people in person for the first time on the day of surgery. And it's also difficult now trying to figure out who do I need to say, nice to meet you in person, and who have I met in person in my office. These are things that I struggle with. I think that if our COVID census continues to rise, we may yet again have to cancel operations. And I do think, and this is a question that I don't know the answer to, but I think it's interesting to think about. Will the decision to cancel a patient's scheduled operation be for the patient's benefit or for the good of the public health? Because I think in the past, when we canceled surgery, I think many of our patients assumed that we were canceling it because we didn't want them to have higher risk. That was part of it. But a major part of it was we also did not want to risk the medical personnel, and we also didn't want to put our scarce resources at risk. And I think it's an important question to think about. Are we sure that we want to fully explain to patients that the underlying basis for which doctors make their recommendations may have shifted from what's good for the patient to what's good for the community? And so if in the weeks to come, and I hope it doesn't happen, but if in the weeks to come I have to call patients to cancel surgery, is it actually important for me to explain to them that my recommendation to cancel surgery may not be for your benefit, but it may be for the benefit of public health? And is that an important thing for them to know? Or if they assume I'm making the recommendation for their benefit, is that fine? So I'll leave you then with just a few conclusions, and then I'll stop. Certainly, this pandemic has led to lots of changes in how surgical care is rendered. I think informed consent has been absolutely complicated by so many uncertainties. I think that our relationships, surgeons' relationships with residents have changed and definitely require greater attention than ever before. We have curtailed significantly our surgical clinical trials. I do think the problem of disparities in surgical care continues with even greater urgency than in the past. And how surgeons are best able to gain the trust of patients in an environment of virtual medicine truly does remain to be seen, and I think should be a source of important investigation. So I do want to end by giving personal thank yous to all of these faculty members and residents who I've listed here. These are all people who co-authored with me some of the papers that I referenced earlier. But I also want to specifically thank the many other surgical faculty and residents who really took great care of patients despite significant personal risks, and were actively engaged in lots of conversations over the past 9 months about these issues and a lot of other issues that I did not have time to touch on. So with that, I really appreciate very much the opportunity to present and look forward to the discussion.
Great. Thank you, Dr. Angelos. That was a wonderful sort of overview of some of the many surgical issues that you and your colleagues had to deal with over the last 9 months. I just want to remind any of the attendees who have questions to put those questions in the Q&A function, and we'll draw the questions from there. So to get things started, Mark Lambert asks, can you elaborate upon your decision to include COVID exposure under the umbrella of patient factors and not as its own separate ranked category?
Yeah, so, I think it was done on the basis of the fact that there were a number of early reports in the surgical literature that suggested that patients who had COVID infections that it was not known and had, relatively small, low risk operations, nevertheless had devastating complications. And so we felt as though that was, it was very much in line with the other sort of increased risk factor issues. And I would say that, today there's now MENTS 2.0 because now, as I said, everybody is COVID tested. And so there is no, it's possible that someone could test negative, come in, have surgery, and then subsequently be positive, and that has happened. But I would say that a lot of the dire concerns about the increased risks are seemingly less of a big risk now than the initial report suggested.
And just a quick follow-up to that, since you mentioned sort of MENTS 2.0, knowing what you know now compared to when you first sort of developed that system, are there things that you would change?
Yeah, I think so. I think that some of the I think it's, is the patient COVID positive or not is clearly, we can know that. We don't have to, go on the basis of, symptoms. I think that it does not appear as though some of the procedure-related factors, which had to do with what part of the body is being operated on, are seemingly not as big of an issue. So there was real concern early on that perhaps doing laparoscopic surgery caused an aerosolization of virus, but that does not appear to be the case. And so some of those factors have definitely been taken out. And then also some of the scale from sort of 1 to 5, making the distinction between 1 and 2, for example, was hard. And so now some of those scales have been shifted. So it's like 1, 3, and 5. So it is certainly there. It's a moving target without question.
And speaking of the MENTS still, so Will Parker notes that it's a very thoughtful approach to a challenging topic. However, without critical care, severe COVID is uniformly fatal. Furthermore, critically ill COVID patients treated at small community hospitals have 3 times the risk of death compared to large academic centers. Can any non-emergency, non-trauma surgery claim such a large immediate survival benefit? And is there an ethical justification for prioritizing non-emergency surgery over COVID ICU care?
So I would say I think that in answer to those are great questions. Obviously, Will. I think that there's no question in my mind that if you have a lack of ICU beds, and as some of my colleagues and friends at Columbia in New York, all of the ORs were converted to ICU rooms, and so all of the surgery was stopped because they were, the ventilators were being used for the ICU, and the ORs were, housing patients. I think that if you're in an absolute scarcity situation in which you are going to take away ICU beds or ICU capability by virtue of having non-emergency surgery, you probably should not be doing non-emergency surgery. And so I think that the MENTS scoring really is of greatest value when you're back into a phase where we have enough ICU beds, we have enough inpatient beds for COVID patients, but now we've got to start ramping up our surgical volume. And so, why do we need to do that? Well, for one thing, we got patients who have surgical problems that need to be taken care of, and there's no question about that. But in addition, the financial well-being of the institution is largely dependent on the revenue generation of surgical departments. And the operating room has to be functioning in order to not lose a lot of money. And I hate to talk about the finances because that is not the fundamental ethical issue. But I think as long as you have beds, and as long as you have ICU beds and staff, nurses, critical care physicians, as long as you have the appropriate personnel, I think doing surgery is valuable for patients for whom they need surgery.
Since you brought up finances a little bit, one question that I have, and it came up in a previous talk about hazard pay for those that are sort of doing the frontline sort of care. So for an attending surgeon who's probably sort of fairly well compensated compared to the residents, but the residents are doing the frontline care, as you mentioned, were there any discussions, or was that part of the tension between attendings and residents in terms of talks about taking pay cuts or hazard pay for those on the front lines?
Yeah, it's a really good question. And there was nationally some discussion about this question. And we actually had a really fascinating department-wide discussion at one point when it was, when there was a lot in the national discussion about this topic. We had our own departmental discussion. And I think that it was striking to me that there were a number of residents who were very vocal in the feeling that that the analogy to war was inappropriate, and that by talking about being frontline workers, that's not the appropriate analogy. And, I can't be as eloquent as some of the residents were, but I had a number of people express things like being a physician is something that they chose to do, and that sometimes it's higher risk and sometimes it's lower risk, but that is what they preferred to do, and that they did not like the idea of being using the war analogy, that was not the appropriate analogy. I think that, interestingly enough, a number of residents said that they very much felt that they were at lower risk than many of the faculty who are older, who have comorbidities. And in that sense, many of them felt that it was absolutely appropriate that the faculty are in the hospital less. Now, clearly that's not a uniform position, but I do think that in general, I think that I don't think that there was a lot of, I hope, but I don't, my sense was that there was not a lot of feeling like the faculty were taking advantage of the residents.
Okay. And sort of on those lines as well, there's a question about if a surgeon becomes ill with COVID, are they eligible for unemployment and disability supports beyond sick leave? And does it make a difference if they are an attending or a resident?
So I do not know the answer to that question. I think that certainly, one, at least if someone's a resident at the University of Chicago or a faculty in the Department of Surgery at the University of Chicago, you don't stop getting paid if you can't come to the hospital and operate. You still get paid. And so in that sense, you cannot get unemployment. As far as I know, if there's increasingly small numbers of surgeons who are in private practice. My understanding is that they are not eligible for unemployment. Now, whether someone would be eligible for disability if they were unable to operate as a result of their illness, months down the road, that I don't know. It's a great question.
Similarly, along those lines, did any surgery staff get COVID from coming into the hospital that you know of?
There are, I don't know the exact numbers, but a small number of people did. A number of people, so early on, again, anyone who was exposed would be taken out and then, quarantined. Now, with much more widespread testing, I think that, it's a little bit easier to sort out, but we did have a number of people early on who were out with, flu-like infections, and most of those actually had the flu and did not have COVID-19, but a small number did.
Okay. Martin Shan asks, when you turn down a patient at U Chicago, do they go to nearby hospitals? So as we were sort of turning away patients or postponing, were they seeking alternative surgeries elsewhere?
Yes. So, it's a great point. And again, I think it sort of emphasizes the disparities because there were definitely patients that I saw that had the financial means and who said to me, well, if you're not going to operate on me, I'm going to go somewhere else. And, I'll go to the Mayo Clinic and I'll get surgery there. And, what I expressed to them was that if that is something that will allow you a greater peace of mind rather than postponing your operation, and they are willing to do your surgery there, then that's totally fine. I can tell you that there was no, for most diseases, there was no sort of coordinated approach. On the other hand, I know that among the breast surgeons in Chicago, there were much wider conversations around the idea that it would be inappropriate for everyone to suddenly shift to another hospital because that hospital still had OR capability. And so there was very much of this feeling that, well, we should be somewhat consistent in our recommendations. And again, for many breast cancer patients, the approach was to utilize more upfront radiation or upfront chemotherapy and delay the surgery. But that was one of, I think, the few sort of coordinated approaches.
Great. So another question is, at this time, do you have a better sense of how delayed surgical treatments impacted overall mortality for patients? In other words, did delayed surgical care for cancer impact mortality rates of those cancers, and if so, how significantly?
Yeah, at this point, I do not believe that we know. I certainly have not seen it in my patients, but again, my patients, if they have cancer, they have thyroid cancer, and the vast majority of thyroid cancer patients do so very well that it's going to be virtually impossible to actually identify a change. I think that for some of the more aggressive cancers, the jury is out, but there is a lot of focus on this question and whether I think that, it does remain to be seen whether the delays actually will impact patient outcomes.
Great. Next question is, in the beginning, we had limitations on visitors, which was quite hard on post-op patients, but this restriction was lifted in the summer. More recently, I have seen a situation where a spouse infected a hospitalized post-op patient who required intubation, et cetera, additional use of resources. Do you have any thoughts on how we approach the important role of families and caretaker, particularly in locales where there is less use of masking or social distancing?
Yeah, so I can't speak to other places where there is much less, masking and social distancing. I can tell you that at least as a surgeon, I think it's really valuable to have a family member in the hospital with a patient who's had an operation. And I think that, I had a patient who's scheduled for surgery tomorrow who ultimately canceled his operation because of our now much more restrictive visitor policies, because, he felt that unless his wife could stay with him, he might not get good care. And so I think it's a real concern, and it's something that we have to take very seriously. The flip side, though, is that, right now the numbers in Illinois are looking a little bit better overall, and you all probably know that as well or better than me. But I think that when the numbers get high enough, restricting visitors, again, it's not good for each individual patient who's having surgery, but it may have public health benefits. And so here again, we're being forced to make decisions about individual patients on the basis of what's good for the public. And this is something that, I must say, I am not well versed at having to make those decisions. I don't generally have to make them. And I think we're all being forced to think about them in a way that we've never had to before. And hopefully this isn't going to go on for much longer, but who knows?
And this question sort of piggybacks on that, about how you did mention the potential ethical dilemma in being transparent with patients about how clinical decision in the provision of surgical care may need to be weighted towards population beneficence versus individual beneficence. And the question is, can you say more about how do you see that playing out in the future?
Yeah, so, I think it's a great question. I guess I feel like so I am now going to, I'm going to now tell you how it feels. This is not a well thought out ethical position, but more, it feels somehow disingenuous for me to say to a patient, based on the way things are right now, we have to postpone your surgery for an undetermined amount of time. And I had very few patients say anything other than, I totally understand, we have to be careful, thank you for all you do, and everyone in the hospital. People tended to be very, very agreeable. But I do think that they were very agreeable because they felt that we were making these recommendations to save them from risk. And that's part of it. We were partially making that recommendation. But it seems somewhat disingenuous for me to allow them to assume that that's the primary basis of my recommendation, when it may in fact be that a significant part of the recommendation is just that we don't want other people in the hospital to be at risk, or we don't want to use up our resources on your case because the resources are pretty limited right now and we might need them for someone else. And so this is one of those situations where I guess I feel like I'm being less than transparent by not explicitly saying, I am now making a recommendation that is partially for your good, but is definitely for the public good. And yet I also have difficulty from a utilitarian perspective seeing what real good is there from me carefully delineating that for a patient, and for them to now feel like, well, it's not so much about me, but it's about everyone else. So, I don't know. I mean, maybe that's a good thing. Maybe we all in America need to understand much more how interrelated we are. But I am torn. I don't know what the right answer is. I would love to hear other people who are much smarter than I am help me out.
Hopefully that will be a topic addressed in a few lectures down the road, when we sort of think about individual liberty versus community and population.
Absolutely.
So I guess stay tuned for that. We'll try to fit in 3 more questions. One comes were there malpractice litigations as a result of turning down patients or denying them care? And how do med malpractice insurers react to this?
Yeah, so it's a great question, and as far as I know, there have not been any sort of lawsuits brought as a result of, for example, delaying an operation or something like that. I do think that if the issue is, well, you delayed my operation, and as a result, it was a harder operation, and I had a complication. I think if it occurred during the time that the ORs were shut down, well, then that's pretty easy to defend. I think that if it occurred in that period of time where there were some ORs open, and so some surgery was being done, but just your surgery, your operation wasn't being done or didn't get done, then it's a little bit harder. And so, I have not yet seen or heard of any such litigation, but I would not be surprised if it occurs. And I do think that one of the interesting questions for me, and again, I haven't seen data on this, but I have some concern that the speed with which patients were rescheduled for surgery did not always exactly correlate with the risk of their medical surgical condition, but also had to do with, how much they kept calling the hospital, how much they kept calling my office, how much medical literacy they had to be advocating on their own behalf to get rescheduled. Now, I did have patients that I called up and said, good news, we can do your surgery. And they said, no way, I'm not having surgery now. You told me that this wasn't an emergency, that I could put it off. So I'm going to put it off for another couple months. That's also, sort of an interesting thing, because once you tell patients, it's okay to put this off. Well, how long is it okay to put it off for? And so we, arbitrarily say things like, well, a couple months is fine, but I don't think I'd put it off for 4 months. What is the basis for which I say that? Well, I don't know. I mean, it just seems like it's a good idea to get your cancer out, but I don't really have any data on this.
Right. Second to last question then is, do you think there will be any surgical advancements that may come out of the pandemic where some modifications and adaptations are needing to be made?
That's a really good question. And I certainly hope that there will be. I hope that some of the advancements will be in the realm of ethics. And I hope that, a better appreciation of how we should communicate risks. I think that's an important thing. I think that for all of us to think about much more seriously how disparities in access impact outcomes, I think that's could be a really valuable thing. I think that it may be the case that we will see that there are certain diseases, certain cancers where non-operative treatment for some period of time does not have a negative impact. Maybe it'll have a positive impact. I would hope that we will learn those things, but at this point, too soon to know.
And I'm going to give Dr. Siegler the last question here, and he asks, did our ethics work and our publications at UChicago by your amazing surgical team have an effect on other surgical programs in the country?
Thank you, Mark, for that very generous question. So, I do think that they did. I think that there was a tremendous level of interest in the MENTS scoring. And I would say of all of the publications that came out of the last several months, that's probably had the greatest impact. And so, I had surgeons from multiple institutions calling about that. I know that Vivek Prashant, who is the first author, has spoken to lots and lots of surgeons around the country. And the American College of Surgeons sort of highlighted that as a way of sort of triaging cases. So that's probably the most significant thing that's come out of it. I would say that I hope that it's, we've had a positive impact in other ways, but I do think that hopefully one additional positive has been that there, I think, is a greater appreciation among all residency programs throughout the country of how to maintain this level of trust between residents, fellows, and faculty. Because I think that the things that we struggled with, I think every teaching institution struggled with. And so I think that hopefully that will also be some sort of a lasting impact.
Great. Mark, I'll leave it to you if you have any parting words, but on behalf of the MacLean Center, I'd like to thank you again for such a wonderful talk and participation in the question and answer. And I'll turn it over to you, Mark, to sign off.
Yeah, Peter, it was a spectacular talk and fascinating, the number of publications that have come out and also the number of people who participated, both in the program and in the publications. I thought it was very moving. If I might just say a final word, that next week's session will be the final session in the fall quarter. We'll have 3 weeks off, I think, until January 6th, when we'll resume again. But next week's program will be by Peter Singer, who was a former fellow of ours and who ran the program at Toronto for 12 years, the ethics program, and is currently probably the #2 person at the World Health Organization. And so next week's talk, as I say, the final talk of the fall quarter, with still 18 more talks to go in the winter and spring quarters, will be by Peter Singer. But I wanted to thank Peter Angelos today for an extraordinary talk. And thank your colleagues for us. It was really very wonderful.
Thank you, Mark, and thank you, Brian, for moderating the questions and answers. It's really an honor for me to be able to present, so appreciate it.
Thank you, guys.
Now, Yolanda, are they moving over to a separate session?
Yeah, they are.
Okay.
All right, thank you, guys.
Thanks, Peter.
All right, I'll move over to the other session.
Oh, thank you. That starts at 1:30?
Okay, is that true? Not right away?
Yolanda knows.
Yeah, we said 1:30 just to give a break.
Okay, great. I will be back on at 1:30 on the other link. Thank you guys very much.
2 minutes.
Okay, bye.